Good morning, Chairman, Co-Chairman, ladies and gentlemen. Today I would like to present the Miss Monteggia fracture dislocation. My name is Piratit Sopana from Siraj Hospital, Mahidol University, Bangkok, Thailand. So many of pediatric elbow fracture have misdiagnosis. The factor that could lead to misdiagnosis include that soft tissue swelling. Sometimes the arm of the children very sharply and they cry a lot. They incooperative, so they maybe misdiagnosis. And another thing is inadequate elbow radiograph. Many of them has plastic deformation of the ulnar instead of obvious fracture. So in the inexperienced doctor, they will misdiagnosis. Another thing is multiple ossification center that may confuse our intern, resident, or even the inexperienced doctor. Many factors could lead to pediatric Monteggia fracture to be misdiagnosis. So this one of the example that patient got the elbow equilateral radiograph, which not include the whole forearm, which we will see that from the right hand side that if we have the whole forearm x-ray, so we can see that the ulna is bending, the ulna has plastic deformation leading to the radial head anterior displacement. So our report on 2018 on BJJ, we conclude that Miss Monteggia fracture dislocation could lead to progressive valgus deformity and causing elbow instability. We also see patients with transient posterior interosseous palsy, and also we can see some patients have joint space narrowing leading to osteoarthritis of the elbow. So from our study from BJJ 2018 and from European Journal of Orthopedic Traumatology 2020, we learned that although patient has aged more than 12, or patient may be neglected of the Monteggia fracture for more than 3 years, if we do operate them, we can have the good result. But in some patients that we operate more than 2 times, but still unstable and re-dislocation, this patient maybe have, if we do the third attempt, this patient could have high failure. Maybe this patient we could do skillful neglected and wait for osteoarthritis or other procedure when patient gets skeletal mature such as radial head prosthesis. And another thing, for the overcorrection of the ulnar, we see 2 of our patients in 30 cases that overcorrection more than 10 degrees. We see that those patients have 2 of them have posterior radial head dislocation. Instead of that, previously they have anterior dislocation. We suspect that this could lead from our overcorrection or not, although we conclude in the EJOS study that we will not overcorrection more than 10 degrees of dorsal angulation of the ulnar. So this is the conclusion of our BJJ 2018, 30 patients. So mean age of the patient was 7.4 years old, and the time for the neglected was 23.4 months. It's quite 2 years. Mean follow-up was 42 months. So for the last visit, at the last visit, the excellent, we're using the Kim elbow score. The excellent condition is in 23 patients, good in 3 patients, fair in 2 patients, and poor in 2 patients. Poor is that patient got redislocation and pain. So majority of the patient, in 30 patients, majority have the improvement of their elbow flexion. And also we have a fair radiologic outcome in 6 patients who has operated more than 2 years after the initial surgery. But when we run the univariate analysis, we could not find which factor that's associated with fair to poor outcome in our study due to we have only 30 patient misdiagnosis. So if we include more patients, maybe we have found the factor that could lead to poor outcome. This is one of the patients that we showed previously. After we do the ulnar lengthening, the radiocapitular is in place and they got full range of motion. So this is one of our patients. We do the ulnar lengthening, but after patient get into the inpatient unit, the resident see that the radiohead redislocate again. And then we will go back to the operating room and check, open reduction again and check. And even annular ligament reconstruction, we still see some of the instability, so we add the transradiocapitular pin for 4 weeks. After we remove transradiocapitular pin, everything is in place. She is in full range of motion with good clinical outcome right now. So our preferred method is that in mixed Monteggia fracture dislocation, we will open reduction and ulnar osteotomy first. It's stable, we will immobilization in supination and flexion 100 degrees for 6 weeks. But in patient which is open reduction and ulnar osteotomy doesn't lead to stable elbow, so we will do annular ligament reconstruction. But if still have some unstable, we will add transradiocapitular pin for 4 weeks and cooperate with CAS. Thank you very much for APOA inviting us. Thank you.